at the meeting after we've completed. The members, if you would like to introduce yourselves, I'm Councillor Habiban Zaman and I'm the chair of the panel. Councillor Armour. We can't hear you.
My apologies, a brilliant start. Councillor Miller, I'm at Kirkburton Ward, member of the panel.
Councillor Warner. Is she with us? Councillor Lunat.
Councillor Fazila Lunat, panel member.
Dave Rigby.
Good afternoon, it's Dave Rigby and I'm at Co-op T.
Lynn Keedy.
Good afternoon, everyone. I'm Lynn Keedy and I'm also a panel co-optee.
Peter.
Good afternoon. Thank you. Good afternoon. I'm Peter Bradshaw. I'm an external member of the panel, but an observer.
Okay, and we have apologies from Councillor Afak Butt and Councillor Vivian Lees-Hamilton. If we can go to item 1, which is minutes of the previous meeting, do we approve those as a true record of the panel held on 7th of October?
Happy to approve, Chair.
Thank you. Any councillors who may wish to declare an interest, or members of the panel may want to declare an interest? Lynn?
Thank you, Chair. Yes, I would like to declare an interest as a volunteer with Health Watch Kirklees and Calderdale, and also declare that I have had involvement in the Kirklees Council projects relating to the integration of the Gateway to Care and Locala single point of contact services, a separate but related project appertaining to direct payments that arise following a Care Act assessment, and a separate but overarching Kirklees Council project relating to the protocols of co-production. Thank you.
Thank you for that. Item 3 is admissions of the public. We have no members of the public joining us today. Item 4, deputation and petitions. We have no deputations or petitions at the meeting. Item 5, public question time. We have Councillor Alison Munro, who has joined us on the call. Alison, would you like to ask your question, please?
Thank you very much. Yes, unfortunately, I found it necessary to complain to Kirklees CCG recently in connection with accessing local GP surgeries, as I have received complaints from residents on this issue, particularly for Almonbury and Waterloo. Residents need to be able to access their surgery. We need systems that are fit for purpose. Simply being told you are 18th in the telephone queue or 25th in the telephone queue is unacceptable. The situation is untenable. I am aware that our local GP practices are likely to be full. They may be even over capacity. I do know my GP works really long hours and is very dedicated and an excellent doctor, as are his colleagues and staff. Something, therefore, is wrong. If our local GP practices are to provide a service that is fit for purpose, where they can deal with patients appropriately, then they must be given the funding to help them expand their practices or locate new premises urgently or whatever is needed, and introduce new systems that work for everyone. If the situation is allowed to continue, people may fall through the net. They possibly already have. I know many people now cannot be bothered to even try to phone their doctor's surgery. Viable solution must be urgently found by the CCG so patients can access facilities and care they are entitled to. Thank you very much.
Thank you. Okay, thank you for your question, Alison. Do we have anyone on the call who is able to give Alison a reply? Alison, it may be okay. Vicky, do you have your hand up?
I do, thank you, Councillor Saman. I can't actually reply because I'm not clear what the question was. I got the essence of your statement, and I got the bit about the CCG and funding. However, what I need to make clear to the members, and I think it might be something you wish to bring back and bring our primary care leads back to, is primary care services are not commissioned by the CCG. They are commissioned by NHS England. We implement that contract on their behalf, but it's NHS England who actually commission that, and that's one of the anomalies about the way that the NHS works. What I can say is that all our GP practices are open. All our GP practices are doing face-to-face appointments, as well as those that have got technology in place to do telephone consultations and video consultations. We are overstretched, as is the whole of the NHS, so we know that our GP is our first point of contact, and it's not good that people are in call queues, but our practices are responding to all calls, and it's the fact that they have to ring at from 8 o'clock in the morning that puts people in call queues. But if the panel would like further details or information on a specific primary care one, I can take that back into the CCG and get the primary care leads to come and do some presentation.
Thank you for that. Is that okay, Alison?
Well, thank you for that. I think my question really is, because I don't know why the telephone systems, clearly the queues are tremendously, they're far too long, because people get cut off after 30 minutes, which is roughly about 9 calls. So if you're 18th or 25th in the queue, you're just not going to get through to your doctor. So is it that they've got too many patients, and do they need to expand their practice and update their systems accordingly? Or is it just that they need new telephone systems or a different solution for people contacting their surgeries? I understand with the Waterloo practice that they are full, and they're totally stretched, and if they're dealing with too many patients, then they are going to have long queues on the telephone. So I think there's a few issues here that really need exploring, to be honest.
Yes, so I think we can bring those back. Just very briefly, I think it's probably a combination of the two, that most of our practices are up to their optimum level of patients that they can carry based on the number of GPs that they've got. We do know that there is an issue recruiting GPs, and there's more GPs retiring, and there's also the natural demographic growth. So I think what we need to do is get those specific questions down, and we take that back and do a specific session on primary care.
Also, Alison, if I can say that what we'll do is, because we don't have the full facts here, we will get a written response out to you. Dave, were you wanting to comment on this item?
Yes, please. It was just an additional point. Vicky described the current commissioning position. Will that change next April with the introduction of the integrated care service?
We don't know yet. It's not being confirmed. We expect that there'll still be the majority of primary care centralised at NHS England, and then pushed down just for implementation, but it's not being confirmed yet.
Okay, thank you.
Thank you. Is that okay, Alison? We'll get back to you on that.
Thank you very much,
Okay.
Habiban. Thank you everybody.
You're welcome.
Goodbye. Thanks.
Okay, so if we can move on to the next agenda item, which is Care Homes Programme Board Update. And we have Simon Baker, who will take us through this item. Simon, over to you.
Thank you. Hi, everybody. My name is Simon Baker. I'm Head of Commissioning Market Development in Adults in Kirklees Council. I've also got with us today, introduce yourselves, guys, Chris.
Hi everyone, my name is Chris Porter. I'm a Service Development Manager working across adult social care in the CCG.
Thank you. Julie.
Hi, I'm Julie Oldroyd. I'm a Senior Manager with the CCG working on Ageing Well, which includes care homes.
Thank you. And Michelle.
Afternoon everybody, Michelle Cross, Service Director.
Headphones are on top of my head. Good start. Michelle Cross, Service Director for Mental Health, Learning Disability and Commissioning and Contracting Services, which Simon and his team are managing.
Brilliant, thank you, Michelle. Okay, so thanks for letting us come today to talk about an update on the Care Home Programme Board. There's been a lot of activity going on, as you can imagine, over the last 18 months, particularly during the COVID period, and we basically just wanted to update on where we are. I realised that we've put together quite a long presentation. So what we decided is we were just going to pick up on some key issues and some key slides within that pack. We didn't want death by PowerPoint for you guys, and that will give us a bit more time for questions at the end of it. So basically, we're going to just cover the work of the programme board, the issues and the challenges of the care home sector, the Care Home Programme Board work plan to address these the issues and challenges. The Cordis Bright key findings. Cordis Bright were a consultants that we commissioned last year to do a market analysis of our care homes in Kirklees. We're then going to just touch on the Care Home Programme Board response to the findings of the Cordis Bright report, and look also at the key training and support questions asked by the panel. Okay, just move forward. Thank you. Okay, so Julie, do you want to pick up the governance structure?
Yeah, this is just a diagram of the Ageing Well governance structure that we've created. The Ageing Well board came into being about July last year, and since then we've kind of defined how the Ageing Well board will feed into the Health and Care Leadership Board and then ultimately to Health and Wellbeing Board. And under the Ageing Well Programme Board, we've got a number of programmes, of which care homes is one programme, but it sits alongside anticipated care, frailty, end of life, our UCR programme and discharge to assess. And the benefit of bringing these together all under that Ageing Well banner is that how we can talk across interdependencies across all the different elements. And we've got representation from the system on the Ageing Well Programme Board, as well as representation heading up these work streams. So colleagues from LACALA, from the hospice, as well as CCG and local authority colleagues heading up the different work streams. So it was just to make you aware of that and how it sits.
Thank you. Just move on. Okay, so the key challenges, issues and challenges for the sector. So as of October 2021, we've got 131 care homes operating in Kirklees with approximately 3,500 beds. Of these 2,760 beds are available for older people with care needs. 64 care homes support older people, and of these 39 support people with nursing care. I think the kind of issue that really what we want to kind of bring out is that over the past 20 months that it's been very, very difficult, and the local situation has really mirrored the national situation in terms of almost a bleak outlook for care homes. The occupancy has been impacted by residents passing away due to COVID and lack of new placements, and so occupancy levels have gone down. This is kind of linked to really a couple of things. Confidence in the sector. I think we've all seen kind of what's been played out in the media, both locally and nationally. And also there's a move really to keep people at home, and people lack of confidence in the sector, and a move to keep people at home and independent as long as possible has kind of meant that the occupancy rates have suffered and gone down. Do you want to move on to the next slide, please, Julie?
This is just to highlight the impact of the COVID against the quality in care homes and CQC ratings. And there has been some changes over the last couple of years, not massively affected, but certainly we've got less homes rated as good, and a few more rated as requires improvement. The kind of support for this. So we've got a really strong, robust quality process through our CHESP, our early indicator and prevention meeting, and we've also got really good relationship with CQC, and we're in touch with them on a really weekly basis to talk about how things are going. So although we've noticed some changes, we've got good processes in place to mitigate against some of the issues.
Thank you. So obviously the key issues and challenges in the sector, workforce is obviously a real issue that again has been played out in the media nationally, and we're seeing it very much so locally. There are just over 4,000 people working across the care home sector in Kirklees, with 70% in direct care roles. Typically these roles are fulfilled on a part-time basis, and there are around 3,500 WTEs and 2,450 WTEs in direct care roles. The majority, 85% of the workforce in Kirklees are female, and the average age is 43 years old. Workers aged 24 and under make 10% of the workforce, and workers aged over 55 represent 25%. The demands of this workforce and the increasing complexity of needing homes has brought an increasing focus on valuing the future of skills required in the workforce. Also, really important point, health and well-being of residents. Keeping residents in care homes well is of paramount importance. Deaths in care homes due to the pandemic are each a tragedy, but health and well-being care home remains important and a key challenge moving forward. On funding, so funding obviously is an issue and a real big challenge across the board. Councillor Lunat, did you want to come in?
Hi, sorry. Just stop before you get to the end, and I'll forget my question. Yeah, really.
Sure. No worries.
Just in regards to capacity and the number of current care homes, I know we've got it in our reports itself, but it might be a good just to kind of just briefly go over what kind of capacity we're working with, what we've got available at the moment, and what kind of capacity and the COVID effects on our care homes.
So occupancy levels have dipped, as we said, over the COVID period. And I think really probably now we're looking at, Chris, would you say it was about 70%, is it?
It's about 80% on average, but different sectors are affected in different parts of the care home sector are affected in different ways. Nursing, for instance, is close to 75% occupancy at the moment.
Older people's residential?
That's the one that's sort of close to 80.
Right. Okay.
And those figures, if that would be useful to the panel.
Yeah. Please. Would that use, Councillor?
Yes, please. Thank you.
Yeah, no problem. No problem. Okay. Is there anything else that you wanted us to pick up?
No, I'll come back to you. It was just on that, obviously, because like you've just mentioned, because of COVID, the numbers are obviously going to dip. But what's going to be the impact in the way we'll be able to offer the level of care, and how that's going to, in terms of the places that we've got, if they're not going to be viable anymore, how is that going to impact on service users being able to access those places? But yeah.
I mean, we'll probably might pick that up later in the market development report that we commissioned from Cordis Bright. But we'll keep that in mind, and if we don't answer your questions, then please come back to it as we go through the presentation, if that's okay.
Will do. Thank you.
No problem.
Just before we move on, Vicky's got her hand up, and I'm not sure whether you're wanting to ask a question, Vicky, or is that hand up from previous? Okay, we'll move on.
Okay. So, other key issues and challenges of the sector, funding is obviously a big issue in social care, and a sustainable funding model and approach to care homes remains a big challenge. There have obviously been some announcements from central government around the way we're going to go forward with social care funding in the future, but obviously we need more detail around that to be clarified. There is a risk that the combination of finance needed to create pay and conditions to offer and attract the right workforce is key, and that reduces the amount of people need to contribute to the cost of their care exceeds the resources that are currently identified nationally. So we have got a real issue with funding going forward as the market changes. The second bit is kind of about the digital side of things, and we know, because we've got a number of key projects going on locally around kind of using digital implementation really and digital projects to support care. So there are a number of benefits that digital can bring to the care home sector. It increases connectivity to health and social care partners to better facilitate joined up care. It provides efficiency in homes because a task can be completed once and shared across multiple reporting systems, and it creates opportunities for residents to connect digitally with their natural support networks. And we've seen some really good work over COVID where residents have been able to connect with their families and friends outside of the home. Okay, just move on. Thanks. Demand. So as in the pack, there was some charts around demand, but demand has fallen and vacancies remain high in part of the care in the care home market. Feedback from the sector suggests that the negative portrayal of the sector in media over the past 20 months has significantly impacted on interest in new care home placements from both local authority funded and those who fund their own care. I think I touched on that earlier about media portrayal. It does have it has been and continues to be a real issue for care homes. There is an expectation that a small increase in demand will be seen as family carers' circumstances mean that they can no longer able to support people with increasingly complex needs at the home. So in the future, the demand for new places in care homes had been on a downward trend over the last decade, and the impact of COVID has meant that the future demand for places is predicted to be lower. The level at which the demand will settle is not clear, but it's expected to rebound to pre-pandemic levels. As outlined in the Cordish Diet report, future demand is expected to be for shorter, more complex packages of support in care homes. If the population predictions are correct that we've seen, then the increase in demand before there will not be an increase in demand before 2025, when the larger cohort of baby boomer generation reach a point where care home support may be required. Future demand has implications for requirements for buildings, staff skills and levels of funding that reflect the complex nature support needed in care homes. This also presents an opportunity to reflect on the council's role as a provider and a key stakeholder in this market. So Julie's just going to outline the work of the Care Home Programme Board over the next couple of slides.
Yeah, so to support the Care Home Programme Board, we've got a huge Care Home Programme of work. Some of the Care Home Programme Board came about following the issues around closure from Oxford Grange, as well as some documentation that came out of the framework for enhanced health in care homes, and our programme board and our programme strategy, as well as our plan, are based on the outcomes that are identified in that document. Very much the programme board is helping us build those relationships and trust with care homes and partner organisations. The programme board is supported by the Care Home Provider Board as well. And I have to say, over the last 20 months or so, we've got really good, strong relationships and can have really adult, grown-up conversations about difficult issues now across those sectors because of the work of the board. And as well as being sort of trying to meet a load of targets that we've got within our plan, it's an opportunity to talk about debate issues and talk about any issues that need unblocking or things where we can improve or work better together across the system. So we've got 5 kind of key areas within our plan that we report against, and this task and finish groups working for each of these areas. So we've got work around quality, workforce, data dashboards, and enhanced health and care homes. You've jumped too quick. This is just a quick summary. It's all right, we're there. Oh, sorry, the last one was market sustainability, which Chris and Simon are going to talk about a little bit later. But this was just a quick summary of some of the work that's happened in those work streams. So we've certainly got, especially since COVID as well, we've got a really strong, robust process in place for our care home escalation and support. That works really well, and we've also made sure that all care homes have access to COVID training, PPE and IPC advice, and all that's working really excellently now. At the beginning we had lots of troubleshooting, but now all homes are well supported in those things. We've also working through some proactive quality assurance visits and virtual support. So we're going back to providing regular visits into care homes and reviewing and supporting them to get their CQC ratings to where they want them to be. With workforce, we're joint working with a larger, more strategic integrated workforce group. We've done quite a lot of things. We've had a fortnightly virtual session with care homes that was at the beginning of COVID, was very much around support and well-being, but it's kind of morphed into being a bit of a training opportunity. So we've had lots of different teams coming to train on various elements to support care homes at those meetings, and they're really well received. So lots of health professionals across different areas coming to support and explain their services, how to refer in, etc. And all those sessions are recorded and available on NHS Future, so anybody who can't attend can access them. We've also developed a wellbeing menu of opportunities, again, that's available on NHS Future. So bringing together all the things that support care home staff in their wellbeing that's happened, been really difficult through that COVID period. We're rolling out culture survey, so we're working with the Improvement Academy in Bradford, and they've got a culture survey process which helps care homes identify areas for improvement, and we're also looking at how they might introduce safety huddles in their care homes, so a daily quick chat together to talk about any safety issues and support residents to make sure they're safe from falls, that kind of thing, as well as medicines optimization, etc. And not added on there, but we've just only this week started talking about Schwartz rounds. So Schwartz rounds are an opportunity for people who work in care homes to talk about their experiences, and it's a bit of an opportunity to share and support wellbeing. So we're looking to test Schwartz rounds as well. For data and dashboards, we've done lots and lots of work with care homes around using the capacity tracker. So that's a national tool that care homes have to update every day around their vacancies, but it's become more than that through COVID, and now they update on lots of things like access to PPE, if they need any training, what their staffing is, are they getting their vaccinations for flu and for COVID. So that tool's become quite a beast, and care homes have been well supported to update it, and they do really well in Kirklees. I have to say we get really good uptake of that reporting, and we're also working with care homes around doing their DSPT, so their data, I can never say it, data security and protection toolkit, which means that they can then access NHS mail via email and share information, which something all providers need to do. So we've been supporting them to do that. Around the enhanced health and care homes element, we've now got GPs, one practice aligned to each care home. 70% of our care homes are now fully aligned with all their residents registered with that one practice, which has made a massive improvement on communication and relationships. So rather than having 7 or 8 practices in and out of care homes, you've just got one, and that's made a huge difference. We're working through how we might improve our MDT working. So MDT discussions with partners, Lacala, the hospice, for instance, as social care, and practices, and involving care homes in those MDT discussions. So we're working on that. There's been some joint working around the loneliness agenda with the council and how we might support people around loneliness, including people in care homes. There's some ongoing work around the bed base. So we've got a community bed base that includes quite a number of different types of bed that might get a bit confusing if I try and explain. We've got a number of types of bed, and there's some changes going on currently around the intermediate care beds, which Lacala manage, and they're beds where people go in for reablement. So where somebody comes out of hospital needs a bit of support to get going again, they might go into those beds for a period of time. So there's some review of that, and also some review of other types of bed base. For instance, we've commissioned some COVID designated beds. So we've got across Calderdale and Wakefield, we've commissioned these beds, and it's a care home in Kirklees that's providing the COVID beds. So anybody coming out of hospital who's COVID positive and can't go back to their own care home bed, they go into the COVID designated bed setting, which is at Croftlands in Kirkburton, and that's working really well. And that care home's doing a really great job of managing those residents while they have their isolation period and then get back to where they should be. And oh, sorry, the phone's ringing. The last thing is we have got some discharge to assess beds, which is another part of our bed base. So again, if people are coming out of hospital and can't go to their care home of choice or can't get back home because their home care package isn't ready, they can go to a discharge to assess bed for a short period until things are in place. And we've got lots of support into those beds, like therapists, to make sure people don't decondition and that they stay as well as they can do. They're only commissioned till the end of March, so we're having to review what happens to those beds beyond March, and that's part of that whole community bed-based piece of work, really. I think that might be my summary. Let's see what's on the next slide, if we can, Chris.
It's over to me, I think. So really, this is to give the panel a summary of some of the key findings around the Cordis-Bright report. Just as sort of a little bit of background, we jointly commissioned Cordis-Bright with Rotherham Council to undertake a diagnostic, working and consulting with providers, consulting with commissioners, both within the local authority and the CCG, and also engaging with the regulator. So we had as clear a picture as possible as to where people were at and what they thought some of the short, medium and long term issues and challenges in the sector were, some of which we've talked about in earlier slides. And we also asked them to look at what they thought, using their expertise in the sector, what future demand might look like, both across Kirklees and in some very specific areas. And as Simon and Julie have already covered, in common with a lot of other areas, vacancies have remained an issue, both the impact of COVID, but it was also a slight downward trend. But the shock of the past 20 months has meant a number of homes have really struggled with occupancy and therefore viability. As you can see there, that's on the third bullet, the number of beds per 100 people has dropped slightly, and we're going to continue to monitor where that line ends up. But there's also some positive steps in that people who want to stay at home for as long as possible are slightly more able to, because of our increased capacity in the community and things like support with equipment and adaptations at home. So more people are staying at home for longer. But when they do enter care, as described earlier, they are entering with more complex support needs, and they are staying for that short period of time. And that's got an impact on workforce skills, the capacity and what happens in the buildings and how care is managed and supported. So they were the sort of the key findings. And in terms of the board's response, it's all been underneath the market management and the sustainability. I just want to sort of run through 4 key areas of work. The Care Association is a key partner. We've had a Care Association for a couple of years now, but what the step we've taken, not as a direct response to the report, but it was a sort of it was a useful encouragement. The local authority and the CCG have invested in the association because they are an important strategic partner, and we want to give them capacity to work with us on shaping the market going forward, because this is very much about doing things with the sector, not to the sector. In terms of contracting, there are a number of recommendations about how local authorities can better contract, be that longer contract periods or the sorts of expectations covered in contracts. So there's a task and finish group working on that, and our local authority contract is due to of the contracting period is due to run out in 2023. So we've made some short-term changes for the next financial year, but our focus of work really is making sure that all the expectations and scope of that 2023 contract fulfill the local authority and CCG requirements, but have been shaped with the sector. In terms of fees and funding, again, there are recommendations in the Cordish Bright report around linking fees to complexity of case or quality of provision. And we're doing some really interesting work across the region to understand what other local authorities are doing around this. But we've also got local providers around the table unpicking our current fee and what it's covering, the elements within it, and how some of those funding proportions have been arrived at. So we've made some short-term changes for the next financial year, but much of our work will be developing that fee model going forward to 2023. And the last block of work is around the assets, because as we expect demand for care home places to reach a level at some point, but that still won't be at a level where every care home will be at a high level of capacity, a high level of occupancy. So it's understanding and working with providers to say, these are the other opportunities in the market. Care homes is one, but there are lots of other care and support business models that might be of interest to them. A number of homes might have been working in care homes for a long time. So it's working with them to make sure that they're really clear what they can do with their buildings differently, what the site might be useful for, if their staff team could be used for something slightly differently. Still within care, but it's protecting and making sure that we make the most of those assets in the market. As part of that, there are lots of individual conversations going on, but we're also trying to develop a programme that is more open to a number of providers around those diversification opportunities. Julie?
Yeah, I think these three items that were actually requests from the last time we visited, which was some time ago. So things have probably moved on a little bit since we were asked to feedback on some of these. One was around the verification of expected death, which was some training our colleagues were given into nursing homes to help nurses verify death and save time, really. So instead of having to wait for a GP to come out and verify death, a nurse could do it in a timely way and support families, etc., in a much nicer and timely way. So there's been some training that's been rolled out in North Kirklees. COVID has halted that training, but there's expectation that we roll it out further across nursing homes in Greater Huddersfield as well, and that's in the plan. Another thing was around end-of-life plans. There's been a great deal of work done around end-of-life plans, particularly through COVID, and certainly our number of residents who've got advanced care plans has increased, I think, by 17% since about over the last 2 years, due to the amount of work that's happened. So a number of teams go into care homes and support care homes with that and provide training, etc. We've got a specialist advice line as well that the Kirkwood offers to care homes, so people they can ring and get advice 24/7 around any end-of-life queries. And we've also got a specialist palliative nurse service that now is available in both North Kirklees and Greater Huddersfield. And those staff provide training education as well as case manage any complex end-of-life residents. And then we've got the care home support team who again are available now across all Kirklees, and one of their key remits is to identify people who might benefit from an end-of-life plan and put them in place. So all those things together have really increased the number of plans that are in place, and people are supported better. The last thing is our weekly home round. So our GP practices provide a weekly home round with every care home, and anybody who was at end of life are discussed and their needs discussed as part of those weekly home rounds. The last point was around testing and swab taking, and I think when we came last time, that was fairly new and a bit of a minefield for people to understand and work and implement. But since, we've had quite a long time with COVID, and now really that's working very well, and the care homes are all very up to date and implementing testing and swab taking as they should be doing, and as the guidance changes, which it does quite frequently, they do really well at keeping up to date and managing that. And through our meetings, our virtual fortnightly meetings, we ask any questions, or take any queries back and feedback to our IPC team, etc., to keep people supported, as well as that we also provide kind of the weekly comms letter. So we kind of do a bit of a mini update in our comms letter as well. So I think where we were last time is very different to where we are now, and Kerums are managing that very well.
Okay, just to quickly to sum up then, the work and structure of the programme board and its plans continues to evolve, so it's an ever evolving piece of work. There's lots of activity to shape the local market. I think what's come through is that we are working very closely with providers to shape the market, and we're not doing two, we're working with, and we're working very much in an integrated approach across health and social care. And there's plenty of really exciting things coming out. So if that's the end of our presentation, and welcome thoughts and comments from the board.
Thank you for your presentation, and it's good to see that there's a wide spectrum of work taking place. I'll open it up to the panel members for comments or questions. Dave Rigby.
Yes, thank you. Thanks for the coverage of the report. I've got a couple of initial questions arising from the Cordis Bright report. In the report, they outline a series of strategic options which really reflect different levels of involvement of local authority in the market. Has the council made a decision about whether to opt for one or perhaps none of those options in terms of the way forward? Because that would obviously set the strategic framework for everything that follows on from it. That's the first question. The second one is, the report is quite clear about the interrelationship between the residential home market and the domiciliary care market, although it's primarily focused on the residential care. Has a similar piece of work been done covering the domiciliary care market? And what about the interrelationship between the two, which seems to me to be crucial? Thank you.
Chris, do you want to pick the first bit up and I'll pick the second bit up?
Yeah, sure. So in the report, I'm not sure if you're talking about the matrix that's got sort of 9 squares on it in terms of the level of intervention. To be honest, we've done a number of things. So the market position statement that we've got at the moment and our work around forecasting has been shared and shaped with the sector. But we're also working on some of the longer term stuff around that, the work around what long-term contracts need to look like, what our long-term fees need to look like. We haven't gone as far as one of the other suggestions in the report was around making capital available, but we are having sort of regional discussions with through ADAS around what that might look like, because it's better to do things on a regional footprint when it comes to that sort of thing, because providers have operations across different local authority areas. But there are a number of aspects of the level of interventions that we've started already and feature in some of the fine detail of those work streams I touched on earlier.
So there's not been a specific decision on what level of intervention to adopt in relation to those 3 Cordis Bright options that were outlined. It's more a kind of pick and mix thing, is it?
A little bit, yes. And again, some of that is hearing the voice of the sector in how far they want us to go as well, which is the important sort of pushback.
Okay, thank you.
And I guess the question around dom care and its relationship with the residential market, obviously our vision in adult social care is to keep people at home and independent as long as possible. And really care homes, as we've seen going forward, we'll be looking at more complex people with more complex needs, and possibly for shorter times. We haven't done a similar piece of work in the dom care sector as we have done with Cordis Bright in the care home sector. However, we have been working very closely with our dom care partners. Just before COVID, we did have particular issues in the dom care market in terms of providers coming into market, new entrants, and we did some market stimulation in the back end of 2019, and we are in a very different position now, even though COVID has been around. In fact, actually, if COVID has helped with our home care market, we've gone from something like 8,000 commissioning 8,000 hours a week back in 2019 to nearly 17,000 hours now. So we can see that our aspiration to keep people supported at home is really critical, and that's working. It's always a really quite key challenge to keep equality across the markets and support them the way they want to be supported. And the way we want to see them in the future. It is difficult, and I'm not saying we haven't got challenges in the dom care market, because we have, but at the moment, we're just trying to we're supporting all of our key markets, and just trying to keep things going and stick to our aim of keeping people at home and independent as long as possible.
Okay, thank you.
Thank you. Lynn, sorry.
Oh, sorry. It was Julie. I was just going to add to it, Councillor Zaman, that the Enhanced Health in Care Homes work that NHS England drives forward is looking to expand that piece of work to other care sectors. So during this coming year, we'd expect to be doing more of the stuff we've been doing care homes with, dom care and maybe supported living as well. And we're just kind of waiting for direction on that. But our care home programme may well extend beyond care homes to the care sector.
Good, thank you.
Okay, Lynn, can I bring you in? Lynn, do you want to ask your question, please?
Thank you, Chair. I've got one or two points and questions, but I don't want to take up all the time, so please stop me if I've had sufficient time. I'll go through them as quickly as I can. I'm just looking at the page in the presentation that outlines key issues and challenges in the sector and shows occupancy for bed vacancies in the local care home market, which is our page 21. And there's a comment at the bottom, dementia nursing capacity, because of its complex nature, has remained at a low level of vacancy or placement availability. And really, I just wanted to ask what's been done to address this, and whether family carers are left facing significant challenges when, for example, their loved ones require care home dementia nursing, but it's not actually available at that time because there isn't a placement where the staff have got the relevant training. Do you want to answer that first, or do you want me to highlight the rest of the things I wanted to mention?
Well, maybe if we take that for now, Lynn, and then come back to you.
All right, thank you.
Okay.
Can I just say, Lynn, that the dementia nursing issue is not just a Kirklees issue; it's much wider than that. So it's Kirklees, certainly across CKW, we're seeing the same things. I think from a COVID perspective, because the demand into care homes has gone down, I wouldn't say it was. I've not come across any significant issues around it, but it certainly is something we need to look at across a wide footprint. I can't remember what the rest of the question was. As far as dementia residential homes, there's capacity in the system for dementia residential, so it's only the nursing element that's been an issue. Internally, I understand the council colleagues are looking at their dementia beds and their in-house beds and how they might reconfigure, so that might help some of the issue as well.
Yeah, Michelle, I don't know if you wanted to kind of add anything from an in-house perspective.
I mean, like Julie said, from a council internal provision point of view, we have recognised that there is some gaps emerging for our complex dementia individuals who need that speedy discharge from hospitals. So we are doing a piece of work that looks at the current provision that we provide, where we would be supporting speedy discharge into some of our in-house provision. But like Julie said, we haven't experienced significant issues in terms of capacity to discharge people. So I think in terms of supporting family carers, we are still prioritising that. So that should give you some assurance, hopefully.
Thank you.
You're welcome.
Okay, thank you for that. Peter, can I bring you in, please?
Thank you, Chair. Just a quick one first. I wanted to ask about workforce primarily, please, if I may, but I just wondered if the compulsory vaccination demand has impacted on the care home workforce at all. We've heard all sorts of scary reports on BBC and in various other media about what it's going to do to your staff numbers, and I just wondered if that was significant in Kirklees, please.
Yeah, in terms of the independent sector, current figures really is a 96% of staff have had their first vaccination, and 92% have had both. And those figures include staff on maternity leave, etc. So there may not be 100%. So I think we're looking probably that there are probably at least 200 people less working in care homes across the sector because of it. So that's not insignificant, but the take up hasn't been so bad. So the take up has been good, and we aren't as worried as we thought we would be, and we've been working very, very hard with providers and their staff to give out positive messages around vaccination. So we have been proactive in working across the sector to meet that challenge.
Yeah, and also certainly some of our care homes where the new staff would leave because they didn't want the vaccination, they've been able to recruit into those posts, so they've kind of had their heads up and time to address any gaps that were likely to appear. But certainly the uptake's it's been gradual and it's taken quite a lot of engagement, but it's really got to quite good levels now.
Yeah, it has. And just to reiterate from an internal point of view, that the uptake is almost at 100% now, but it's taken a lot of time and a lot of effort. And I think it's praise to some GPs who have been out and done some myth busting sessions with staff, which has really, really helped, particularly amongst the young cohort of individuals who are really frightened about fertility and getting pregnant in the future. That's kind of demystified some of those issues for those young staff. But what we seem to be seeing now is that people are wanting to come into the care sector. We've been incredibly proactive in our recruitment campaign to say, come to social care, it's a great place to work. I think nationally there are some pushed out messages that looks at social care as a career of choice, so that really has helped uplift some of the messages around care and the sector.
Thank you. That really leads me to my main question, please, and that really was about the high vacancy rate that's around in the sector, and about really what you know about that, and what you know about attrition, and what you know about those people who stay. Because often, if you know more about those who stay, you'll be able to do better with those who are planning to leave. I just wanted just your general comment on it, please.
You don't want me to take that? Sorry, I've got some kickback. I don't know if everybody else has. You can hear yourself. Sorry. I mean, there's a variety of reasons. I think in the care sector, it's a predominantly ageing workforce. you know, predominantly female, certainly from an internal and external point of view. People have chosen that as a career of choice over many, many years, and attracting young people hasn't always been that easy. And we are seeing, but again, like I said before, we are doing really proactive recruitment campaigns across the sector. We're doing that across the region as well. There's a regional workforce group that looks at how we recruit people into the sector and making that attractive for individuals. And I think we are also looking at, from a workplace point of view, about pay grades and that parity across local authorities, because quite often what seems to happen is we will pay one certain rate and another authority will pay a higher rate of pay, and we're trying to sort of mitigate some of that by working across the region in terms of parity across pay scales. So it is for a variety of reasons. What tends to happen when people come into care is they stay for a long time, or they come and it's not for them. So I think it is for a variety of reasons why people stay or people go. I think from a Kirklees point of view, we have quite good terms and conditions, and I think the relationship with management and the independent sector is really strong in Kirklees and across partners, and I think people can actually see that the whole system is working to support them. So I think there is some real positives about working in Kirklees that people tell us, and I think we do get feedback from the workforce that say they do enjoy coming to working and staying in Kirklees. Does that answer your question?
Yeah, please. But is there any chance anywhere, Michelle, of there being sort of a career pathway, you know, for coming in? I'm thinking about youngsters. I realise the people who stay are in the 40s by and large, you know, on average.
Yes, sorry.
People. Yes.
Yeah.
No. I mean, I didn't ask that, but it's just as it seems. If there's a career pathway, it's an attractive thing to do.
Yeah, absolutely. And those are some of the things we're thinking about. We take people through apprenticeship schemes. We take people from university. There are a variety of sort of ways that people can get into sort of social care. We're doing a project across the sector around project search, where people are coming in through a variety of means as well. So I think career pathways is something we have to consider as a whole sector, not just from an internal point of view to the council. And I think if it's a career of choice, what does that mean, and what does that look like in terms of that career progression? And like I said, there is a regional workforce strategy group that meets regularly that's looking at all those issues.
Thank you very much, Michelle. Thank you. Thank you, Chair.
Thank you. Councillor Leslie Warner, do you want to ask your question?
Thank you. Actually, it's just following on from what Peter was saying, because whilst I accept a lot of work, and I know a lot of work is being done on recruiting, etc., I'm just still a little concerned at the lack of standardisation of basic pay rates. I know, you know, the classic things about care is that you only get paid for your hours of work, you don't get paid for travel, you don't get paid holidays, travelling. And whilst the new social care cooperative that's set up in Slough is offering much better conditions, they're struggling to recruit because they're saying quite a lot of people are setting themselves up privately. And I just wondered if you are going to find yourself, or we're going to find ourselves, as more people don't want to go into care homes, but more people want to stay at home longer, but we're going to have to put it on a more professional footing, like really value people and care, and not be seen as you pay more to walk your dog than you do to look after old people. And whether you can bring that in as a statutory requirement.
That's very true. I mean, we find in that our particularly domiciliary care agencies are having to find workers from an ever decreasing pool, because other industries coming out of COVID are coming back into things, the service industries, the entertainment industries, whatever, are paying a lot more, and so it is difficult sometimes to compete with those organisations, especially when you can get paid probably £15 an hour to pack boxes. So it is very difficult. So we've got to really kind of look at the people to attract people. And I think, as Michelle has already said, we're doing a lot of those things to attract people, but it's also about retaining and looking at key terms and conditions, particularly. I know we're moving away from the care home side of things, but in the domiciliary care sector, is looking at how people's working day is structured, and they're not going into work at 6 o'clock in the morning and still at work at 10 o'clock at night, and only earning 5 hours of that in that time. So we are working very, very closely with providers and the sector. We've got a very, very good project in Kirklees called Intercare, which as a whole. So there are lots and lots of things we can do, but we realise this is a really, really difficult challenge.
Can I just add, it's been a difficult challenge for years, and under COVID it's just got a lot worse, because I know people who've dipped into it because of caring, wanting to do it, but just then they can't live on it. And we all know, getting a place to stay, particularly in an area that's really popular now, like the Combe Valley, and pay your rent and do everything else. So I just wonder at what point we're going to say, there should be a minimum requirement by law, and it's just so piecemeal at the moment. And, it just worries me for future provision. That's all. It should be the most as valued as any nursing job is, and even then nursing jobs aren't always valued enough. So.
Absolutely agree.
Yeah. And I don't think we disagree with the council on. It's just that it's a national issue. It's something that we are trying to work through locally, and as national minimum wage starts to almost compete with what councils pay. We need to think differently about how we engage with the sector, and like Simon's quite rightly said, we need to work with the providers to sort of say your pay scales are matching ours, and how we're going to do that as a collective. I think the Care Association will be a real strength and a lever in ensuring that they have a voice about what they pay their workforce, because they equally are as worried as we are. It's really hard to compete with hospitality at the moment because they are obviously paying more. Terms and conditions aren't as good, but they are paying more. And I think what we might find, and hopefully as things kind of settle into next year, that people actually want a career, not just going out to get working in a bar, whatever. But it's really, really difficult without that social care settlement that obviously we've all been looking for from the government. It's really hard to determine, and there's no right answer, and it is a worry and it is a concern. But I think from a Kirklees point of view and a senior leadership point of view, we are trying our best, and I think the engagement that we've got with the sector is as strong as it is anywhere else, and we can only do it by doing that together.
Thank you for that, Michelle. Dave, can I bring you in?
Yes, thank you. It's a question from the Cordis Bright report. It's on page 27. There's reference there to care home provision for people with learning disabilities. And it does say in there that Kirklees has the highest rate of provision of care home beds for people with learning disabilities in Yorkshire and Humberside. And there's also reference on page 38 to a relatively high number of out-of-area placements for people with learning disabilities. I just wondered what the implications were of those two figures, and whether there's a strategy for looking at what future provision should be made in that sector.
Simon, do you want to answer that?
Yeah, I mean, Michelle might be able to answer from a learning disability perspective, but yeah, we do understand that there are a lot of external placements, and that we are working with that market to understand what the future needs are of it. Work with people in transition for young people. And look at what we can provide in reach over the next few years. Really, it's just about thinking forward as much as we can. Really, and that's the key thing for me. Michelle, if you want to add anything to that from a
I mean,
That'll be
I can do.
excellent.
Vicky's turned a camera on, so I'm
Right.
assuming that Vicky's going to answer some of
So,
that as
yeah.
well, along with myself. And there's been a whole raft of work around learning disability out of area placements, and we do have a level of complexity. We had the Transforming Care Partnership where we did look to bring in people who have been placed out of area back in area. There's been some complexities with that, hasn't there, Vicky? But we have been successful in bringing some of our very complex individual learning disabilities back in area. And there is a whole strategy about how we do that longer term in terms of long-term plan. The difficulty is when you are planning to bring people who have got those complex issues, it takes time in terms of appropriate buildings and where people are going to live and appropriate accommodation. And sometimes that can take up to 3-4 years to make sure that we've got the right support and infrastructure that surrounds those individuals. But that said, we do have a long-term strategy for bringing more people back. Vicky, do you want to add anything to that?
I think the only thing that I'd add, because you've said it all there, Michelle, is that across Kirklees we are well on track with our national trajectories, even though nationally the picture doesn't look good. And I'm not saying we're perfect by any means, but we certainly are not placing people out of area like we were in previous years. We are bringing people back. Those that have to go out, it's for very complex requirements, and there is a very robust process in place for reviewing those people at a whole system level before we even agree to doing the placements out of area. We know that those people that are still out of area to come back are very complex, very challenging individuals, and we are in constant communication, not only with the individuals and their placements to make sure that they're safe where they are, it's the right placement and it's meeting the needs now, but also what their future needs and wants are, as well as how we can meet them, but also with NHS England, because of that complexity, because some people have certain restrictions on them that mean that we can't actually bring them back into Kirklees. So because we're now getting to the much more complex and the very few in numbers, we are working with NHS England and the West Yorkshire ICS about, is there opportunity for us to work on a slightly bigger footprint? So some individuals might still be out of area to Kirklees, but will be back within the West Yorkshire boundary, because that's where we've got the benefits of getting them in the right placement with the right workforce. So it's still a massive priority for us.
Yeah, it is.
I'm just thinking, with the high number of care home beds for people with learning disabilities in Kirklees, the highest in Yorkshire and Humberside, is it that other areas are tackling the need for the provision of accommodation in a different way, as opposed to using care homes? That was the first point. And secondly, is there a mechanism for the involvement of people with learning disabilities, their parents and representative organisations in this long-term strategy development?
You're talking, Vicky, but your mic's on. Talk for you. Absolutely.
Yeah, absolutely. So taking your second point first, yes, we've got a whole engagement exercise. We use experts by experience. We're working with families, and every step of the way, whether it's developing a hospital service or a community-based service, we've got that fully embedded in what we're doing. We're all at different places across the West Yorkshire region, so we've actually brought a lot of people back and got them into supported living, independent living tenancies, not using care homes as such, which is possibly why we've got some vacancies, etc. within that. I think the other thing is what we've found, and we're trying to push back on a little bit, is being a bit of a net importer. So because we do have some facilities, we are finding that areas that are really struggling are asking, not even asking sometimes, but are trying to place within the Kirklees boundary. Right. So we've had to have very robust discussions with like Leeds, etc., to try and make sure that if they're going to place, they're going to retain responsibility for their own population. They can't just do a bit of a shunt because it suits them, because we've developed services. So we are very mindful and watching that really closely.
Okay, thank you.
Thank you for that. I'm sorry, I'm going to have to bring this item to a close, because the officers on the next item will have less time, and they've got another meeting that they need to attend. So in terms of this item, if I can thank the officers and the partners for presenting this item to the panel members, and recommend that we receive the report and the information that's being presented to us. And we can request further information around the occupancy levels.
Yep.
Yeah.
Okay. And yeah, and maybe invite you to a future meeting. Is that okay?
Yep.
Thank you very much for attending.
Thanks
that.
very much.
Thanks very much,
Cheers.
everybody.
Thank you.
You're welcome.
Take care, everybody.
you.
See ya.
Bye.
Bye.
Now, before we move on to the next item, I'd like to have a 5-minute break. But if members of the panel can stay on the call for a couple of minutes to have a discussion before we move on to the next item, if that's okay. Hello and welcome back to the meeting. We are actually on item 7, and one of our panel members, Lynn Keedy, has had to unfortunately leave due to a pecuniary interest that she's declared to the panel. We will continue with the item, and if I can ask the officers to go ahead and start presenting. Jane Close.
Thank you. So what we've prepared for committee is in response to a number of questions that were put to us in relation to the work plan, predominantly around adult community services and predominantly around the work that we're doing in partnership supporting the admission avoidance agenda. So the first element of the report that you have is specifically in relation to the excellent work that we have done around integration of health and social care and a number of our services working together, specifically around supporting discharge to assess, admission avoidance and intermediate care service offer. There is an update around the urgent community response pathfinder, and then an update around our intermediate care bed provision. The hospital support significantly focuses on the discharge to assess pathways that were put in place as a result of COVID and have continued since and will continue. And then some information in there around some initial scoping work that we've done around providing a same-day urgent response, but from a community point of view. So you'll have heard from an acute perspective, they've got something called SDECs, which are same-day emergency response wards, and we're looking to replicate that in a community and predominantly in our WIC service over in Mid Yorks for trial purpose over the winter. And then the last element is in relation to the proposed merger around our single point of contact and gateway to care. So the information's in there, and we're happy to take questions from panel if anybody has anything.
Thank you, Peter. Would you like to ask your question?
Thank you, Chair. Jane, if I could take you to page 44. It was page 44 of our papers. It's the point where you talk about developing a same-day urgent emergency response model in the community in conjunction with primary care networks. I'm assuming that means GPs.
Yeah.
And really, I wanted to know whether, I assume that this is going to take pressure off the hospital in some respects, pressure off A&E in particular. And I wondered where, how you recruit the patients, where they come from, and how they'd access the scheme if they knew about it.
So Peter, and apologies, it becomes a fast-moving thing, does this? So as the report was written, it was absolutely to recruit patients via GP practices. So for those patients that are triaged that need an element of same-day response and may, for instance, need some diagnostics, so some blood tests or an X-ray or something.
Yes.
Since then, what we've looked at is, because of the National Directive of Travel, particularly around the pressures in the ambulance services, what we've started to look at is having a model where we will triage some patients, and they're called category 3 and 4 patients. So those patients at a lower level of need. So we will triage those patients through our urgent community response, both from 111 and from YAS and from GP referrals. And if it's deemed necessary that they need some oversight through community same-day emergency care, that's how we'll recruit them in the first instance. And then we will look to broaden it out to take GP referrals from primary care as well.
So what sort of levels of acuity are we looking at, Jane? I mean, obviously these are probably self-limiting conditions, are they, or things that are going to contain themselves?
Yeah. So
potentially. Yeah, sorry.
It's all right. The kind of things would be the reason that we've based it in the WIC with some. This is the plan, that we have it in the walk-in centre at Dewsbury with some GP oversight in there, and it will be for those patients who potentially need some diagnostics, so a blood screen or a chest x-ray, for instance, that becomes the here and now. And it is our attempt really to see if we can support the pressure in the ED department from a slightly different angle. And the beauty really, from my point of view, of putting it in the WIC as a trial basis is that we've got the close working relationships with the emergency department as well.
Right. And I mean, and would you be getting to levels of sophistication? I know it's not sophistication where you'd be hydrating people with intravenous infusion, or you know, what levels of intervention would you be looking at home?
Yeah, so at the moment at home we already provide intravenous antibiotics, for instance. So yes, there will be a level of sophistication in the pathway that says the patient seen at community SDEC, actually what they need is antibiotic therapy, and they will track through having the cannula put in the hospital and then back out into community. The intention being that we don't need to have people admitted for that element. That's one example. But I'm more than happy, Peter, once the pathways are worked up, because currently they're in development, to supply those through to OSC or come back at a later date and discuss it.
No, that's very helpful. Thank you very much. Thank you, Chair.
Thank you. Dave Rigby, do you want to ask your question?
Yes, thank you. A couple of questions. First one's on the same day response model. You've got a bit on page 45 about progress to date, but it's a bit difficult to get a feel for how things are going there. And do you have a kind of indication of how things may develop in the future? And is it the intention, if the pilot is positive, to roll out the scheme across primary care? And then well, do you want to take that one first, and I'll ask the next question?
Yeah, please. So, Dave, what we've done is the scoping work, and the signs are that it's positive in terms of being able to access a locum GP to work with us, because at the moment we don't have GP support in there. It's ANP run. The rest of the kind of how it'll work is currently in development, but with an absolute understanding from our point of view that it needs to be up and running shortly, and it's going to be almost a work in progress as we develop it, because I think if we wait to develop it to the nth degree, I'll have missed winter. So it's kind of starting and then building up on that. So that's the plan.
Right. Okay. Thank you. And then the other question's on page 47. So it's to do with the merging of the gateway to care and the single point of access. A couple of things. There's a reference at the top of page 47 to the training of call handlers that's going ahead. And it says that 2 gateway staff will join the pilot once capacity allows. I mean, it's something you'll obviously be aware of, but on anything like this, I imagine it's really crucial to have the training done with all staff together, if at all possible. So that's the first point. And then again, I wondered, is there if the pilot is successful, or if the initial inquiries are successful, have you got a target date for when you might introduce the merger?
That one's an easier question, Dave. I'm going to hand over to Rachel to give you the level of detail.
Thank you.
Afternoon. So there's actually been a bit of movement since we put this report together, and we've now identified 2 gateway to care staff who can come and do the training in local or single point of contact. So we have got the 2 people now from each organisation working together as a team of 4. So the idea behind that is to understand whether a person can understand, a single person can understand enough about how gateway to care works and how the Locala services work to be able to answer any query that comes in rather than having to transfer it to somebody else. So we've got quite a structured training programme around that, and we've given ourselves until January to actually test that out in real life with those 4 people working together. And based on the learning, we've provided our blueprint, which was put together with the colleagues in both organisations, and that's their vision of what they want their integrated service to look like. So based on the learning that comes out of that, the intention is to create a service that has that shared role right at the front. So the person picking up the call and speaking to, whether it's a citizen, whether it's a carer, whether it's a colleague from another organisation who's supporting somebody, that they can answer and resolve as much as possible within one call. We're already seeing some positive signs of that. So we've made some progress around being able to transfer calls between the respective organisations, but we've got some early signs that that training is going well, and that people are getting some really interesting insight into each other's role and what they might need to do to make that work.
Yeah, good. That's good to hear. And just a final point, is the intention to have strong links with the SWIFT single point of access, so that where there's overlapping issues there, you've got some consistency?
Yeah, I think as we progress with that, and we've already got some elements of particularly SWIFT's older people's mental health referrals that already come through single point of access for us. Right. But yes, I mean, ideally we'd have one true single point of access for all of the health and care services across Kirklees. And I think if this proves to be a success, it'll give us an opportunity then to start talking to other partners in the health and care system about how we bring it all together under one umbrella.
Yeah, okay, thank you.
Thank you. Councillor Smage, do you want to ask your question?
Okay, thanks. I was just wondering how much capacity this would put extra into the system, and when are your pilots due to finish and programs to actually start across Kirklees, and how much demand are you expecting to take from hospitals and primary care? Thank you.
In relation to community SDEC, Councillor Smedge?
In relation to all of the initiatives.
Okay, so in relation to community SDEC, we have modelled that we'll see 240 patient appointments across the 5 days. The GP element will run Monday to Friday, 12-hour days. So that's the capacity for that. Again, it's very much a pilot. We haven't done anything like that before, so it will be closely tracked to see what difference it does make, and it will run, we hope, from the end of November until the end of March, so across the winter period. The Gateway to Care and SPOC is less about extra capacity and more about streamlining the service, so that actually the person, the citizen, the patient who rings in only needs to tell a story once. Again, that will be part of the key performance indicators and the learning and the intelligence that we gather as we go. But from my point of view, it can only be better for somebody that rings, that doesn't have to repeat their story. The biggie probably is in the intermediate care services, because you will be aware the UCR service that we've got is a pathfinder service. So we were part of a number of pilots nationally, and obviously by the beginning of April that has to be business as usual, and that's why there's quite a significant chunk in the report about how we've remodelled the intermediate care stroke admission avoidance pathway. So I'll ask Helen if she'll just come in and just give a level of detail, Councillor Smage, around that.
Yeah, so I mean, looking at the new discharge to assess model where we've got integrated with the local authority, on a monthly basis, we've got about 900 people we're supporting out of hospital who's got a health and or social care need, and that's getting people onto the right pathway, whether it's intermediate care, into a discharge to assess bed, or into sort of the long-term package of care. Looking at our urgent response, so we've supported in a 12-month period 1,400 patients just from our crisis response element for our advanced clinical practitioners, and then within our rapid response, which is our short, can send somebody home, because we do know that somebody can their rehabilitation can be more successful in the home environment. So if we can get somebody on that pathway, we've had an increase of 17% of reablement interventions, which we are looking towards that home first model. So those are all the individuals that we've managed to support coming out of hospital and avoid to go in already, and it's really positive. And step forward, it's about how we do integrate even more. and how we are working with our primary care colleagues around that and working with secondary care to improve those pathways, which is really good for our patient experience.
Thanks. I was asking because of the dependencies on primary care and community services on hospital reconfigurations, and with business cases due. I was just wondering if you had, as part of all of this work, been involved in providing information for business cases for CHFT so that they could model whether the capacity was there in the system for their plans.
Yeah, we have.
Thank you.
Is that okay, Liz? Okay.
Yeah, that's fine. I'll wait to see the business cases. Thank you.
Okay, Councillor Warner, do you want to ask your question?
Thank you. Yeah, it's just clarification, really. And only because of one or two case studies I've been involved in terms of people contact me or people I know. For an older person, the complexities that there now are and the methods of communication. So if you've been in hospital, as this one particular person was last year over Christmas, in and out over a 4-week period for some quite major things, including a stroke, they come back, they're then relying on their local GP practice. But there seems to be an issue, and I just wondered how much this was repeated, about communication. So for example, this person contacted me the other day saying she's very breathless, has been for ages. I'm just really worried. It's getting worse. And she was waiting in because she'd been told to expect an appointment on a telephone, because that's more and more what we're used to doing. And then it turned out that actually she was meant to have gone in for an appointment, and she didn't. She said it was never made clear. So she had an appointment. And then now she's been told she'll go to the back of the queue again for an appointment. This is someone with breathing difficulties. And I just wondered if you have allocated particular staff for vulnerable older people who will check up on people like that. Because I just wondered if there's some people, being missed through the complexities of the change that are going on and the demands that are being made of GP practices.
So, Councillor Warner, we don't deliver GP services as such. I think Vicky's still on the call, and if you want to email the specific detail, I'll happily take that up with the head of primary care services, either me or Vicky, who will be able to look at the GP practice for that. I'm assuming you mean that we're waiting for a call from a GP, not a district nurse.
I don't. Basically, they need someone. There are 2 or 3 people I've met who would like to know there's a named person who's going to ring up and check on them from time to time, because there's a lot of anxiety around. And that sort of, the equivalent, what would have been a district nurse in the past. And that presumably is not coming from the GP. I presumed it would be part of your service.
So, I agree with Jane. I think we need to understand the specific details and
okay.
Where these patients hit services. So there's certainly some models within our acute trusts where those patients that are on waiting lists are followed up while they're on the waiting list to make sure they stay engaged and they can move up and down the list if their condition changes, etc. So we need to understand where that is, and again, one of the things that we're doing, and I think Jane's mentioned this, is how we take learning from other parts of our system and build it into our, in this case, community offer, but vice versa, how we share learning back. That does include primary care. So if there is some learning about the accessibility to primary care and how we can build on the social prescribing model, etc., the health and well-being facilitators that are going to be coming online at some point in the future through the additional roles, we can take that through those dynamics and take it to our primary care colleagues.
Okay, thank you.
Just to come in on that as well, I think that has been identified in some of the pathways around our discharge to assess. So what we are looking at is those people coming out, and we have done engagement with primary care. We can do some check-ins. So if they come out on a discharge to assess pathway, we can do a check-in the next day, because not everybody gets the right information in hospital. They're being moved to come out. It gets a little bit confusing. So we are putting in there for those that are coming onto that pathway. but 50% of the people come out not needing any additional health or social care support. So the local authorities working on a bit of a discharge pathway on how they can work with social prescribers, how we can work with the voluntary sector to do some of that and pick some of that up. And they've got what they call discharge lounges in hospital, and they're trying to get some volunteers to be able to communicate and work with the people coming out, just to say, this is what to expect, this is your GP, this is what you've got going there. So that is a piece of work that's going on at the minute, but it is acknowledged of how we can support that as a wider system. So it is on our radar, but any examples would be really useful to come through, and I wouldn't mind looking into them, particularly if they come out of hospital, I can look at those.
Thank you, Helen. If Councillor Warner can actually put that in an email to maybe Yolanda, and we can forward that on to the appropriate service and get a detailed response back that you can take to your residents. Thank you. Is there any further comments, questions for Locala? Okay. In that case, if I can suggest that the panel considers the report, and what I'd like to see in the appendix section on page 51, where you've got how it feels in that section. You've got as a team member, as a line manager, as a service user, if you could include some further information about as a carer and as a community partner, that'd be useful.
We will do.
Is that okay? And other than that, thank you very much for attending this afternoon and giving up your valuable time. I know you've got busy diaries.
Thank you.
And thank you for attending.
Thank you very much.
Thank you. Bye. Bye-bye.
Bye-bye. If we can move on to the next agenda item, which is the work programme, and if I can pass that on to Yolandi to take us through that.
Yes, certainly. So not a massive amount has changed since you considered it last meeting. Just added one item on number 16, which is the reconfiguration of bed capacity in Kirklees, supported with intermediate care and dementia care. So it's around some proposals that officers would like to come and discuss with you around the care beds that there are at the moment: Molins Grange, Castle Grange, Ingrove House and Claremont House. And it also includes a temporary decant of the Homestead Day service. So the officers would like to come and discuss that with you at the next meeting if panel are agreeable to that. Just in terms of not the next panel meeting, which is, so we've just added that reconfiguration of bed capacity, so that will be discussed with the CQC, because obviously I think the CQC is quite a big item. So the reconfiguration of bed. Leslie, did you want to add something to that? Oh, sorry. Okie doke. So then on the 9th of February, we'll be discussing the direct payments and the changes to that. That's to be confirmed yet, just with officers as to when the most appropriate time to be considered. But then the second item on the 9th of February is mental health and well-being. So if we go back to the work programme, number 5, obviously it's quite a large area. And so I think what we need to do is think about focusing down on a couple of areas. And I just wondered, I know in terms of the CCG, they've said that perhaps some older people's services in the community, that would be something that they're doing a large piece of work on at the moment, that they'd quite like to be able to come and discuss that with you. And then also the suicide prevention is something you've mentioned with public health. Do you all agree that those are the two that you want to discuss in more detail, or do you have any other further comments about what focus you would like?
That's fine with me.
Yeah, so if we take
I'm okay with that.
Yeah, I think we should keep suicide on the agenda if we may, please.
Yeah.
Councillor Lunat.
And possibly, sorry, Yolanda, just about the wellbeing and support for unpaid carers kind of thing.
Yeah.
But obviously, because of COVID and everything else,
yes,
a lot of people obviously who probably weren't possibly thinking of themselves as carers have now started caring, and there's that whole bit of support for them. So I think that's quite
yeah, and
that should look into, yeah.
And that does fit in a little bit to what we've heard today, doesn't it? About that they're going to get to that point where they're going to want those services perhaps from those care homes. So it just kind of fit in a little bit, doesn't it, with that? Yeah. Leslie, did you want Councillor Warner?
Just wanted to come back in again with, I know you're saying you can only do so many and it may have to be another time, but again, young people's mental health, which was a focus for some money that as ward councils we were able to give support to last year. And yet we've not been able to continue that because we've had to put the focus elsewhere on the active travel, which, you know, there can be a little bit of overlap, but I do, you know, it's an area of concern, the ongoing mental health issues with young people and the 2-year waiting list with CAMS, etc., etc. So, I mean, even if it was update on figures and any potential plans to streamline this service in consultation with schools or whatever.
Yeah. So that's quite a lot, I would say, for a brief for one. So I'm just wondering whether perhaps we could have a discussion, Councillor Zaman, about the older people services and what that, with officers out of a panel meeting first, to understand what that would look like, and perhaps we could focus on the suicide and young people's mental health along with the unpaid carers.
Yeah, maybe at the March or April meeting.
Yeah, okay.
Is that okay?
Thank you ever so much. Yeah.
Okay, well, thank you for that. And that brings us to the end of the meeting today. Thank you to all the panel members for attending and the staff who have attended to support and ensure that the smooth running of the meeting, and particularly for Yolanda, it was her first meeting alone. You've done really well, Yolanda.
Thank you.
Well done, Yolanda.
Thank you.
And see you all at the next meeting on the 7th of December.
Which is a Tuesday rather than a Thursday, just to remind everyone.
Thank you.
Okay.
Thank you.
Thank you. Take
Bye.
care.
Thank you very much.
Bye. Bye.